Okay, this is the second chapter in our textbook, and there's a lot of stuff in here that is pure gold, and especially in these opening pages. So I'm going to go pretty slowly through the opening section of the chapter, and then once we get to some of the anomalies, some of it is, especially the hereditary stuff, it's just helpful to know it because they have distinct appearances on radiographs, and particularly if you're working at some of these orthopedic clinics, you'll be asked to do things like scoliosis series or bone age or things like that. So it's helpful for us to know that. But the real meat of this chapter is in two areas. It's in the opening pages, all these special terms for the bones, and then in the section on arthritis. So the learning objectives I've identified is, again, anatomy and physiology of the skeletal system, particularly some key terms related to the actual anatomy of a bone, which may be a funny way of thinking about things, but we do need to be able to describe the anatomy of a single bone, right? What's the inner portion of the bone called? What are the areas of the growth plate called? Things like that. Then we're going to look at signs and symptoms and diagnosis and treatment for all these different pathology here, and finally we'll talk about the impacts to a limited degree on radiographic technique. So for the A and P of this stuff, what we're talking about is 206 separate bones. 126 of those are in what we call the appendicular skeleton. That's things like the appendices, like the arms, the legs, and then the section basically from the skull to the tailbone we will call the axial skeleton. And that there's roughly 80 bones that make up the axial skeleton. There can be variations within those, right, which we'll look at some of those variations now, like additional vertebra, additional phalanges, things like that. These are composed mostly of calcium and phosphate, yeah?
What is it when someone has a tail?
I honestly don't know. There is a term for it, and it is a congenital anomaly, but I can't remember the name for it.
Is it bone or?
It's mostly cartilage, and sometimes it has some muscle in it as well. The calcium, so about 80% of the calcium found in the body is located in the bone, and a significant amount of the phosphorus or phosphate in the body is located in the bone. Because calcium phosphate is a large part of what makes up the bone, that molecule. Or I should say that molecule. So this is going to function. The function of the skeleton is the support of the body, protection, especially for things like the heart and the lungs, movement, it supports movement, and blood cell production. This is the part where the real meat is, and the part that I want to make sure that we're real clear on. And so this begins pretty much on page 18 in this textbook here, and it continues through page 20. So it's not a big long section, but each of these 2 pages filled with some important stuff. And each one of these key terms we need to be pretty familiar with. So there's 2 different types of bone tissue. There's what we call compact, and that's generally the outer portion of the bone, and then cancellous, which is sometimes also called spongy bone, and it's the inner portion of the bone. That outer portion is a large part of how the bone maintains its structure, right? And then that inner portion, the cancellous material, is what houses things like bone marrow, so it's responsible for supporting blood cell development. All the long bones have what we refer to as a medullary canal, and so that is going to be an area, and if we look on figure 2.2 in the textbook on page 19, this medullary canal is an area that's surrounded by the compact bone, but then it has a center of cancellous bone. And so that is where a large amount of the production of red blood cells and white blood cells is occurring. It's in that medullary canal. So it's full of undifferentiated cells. that are eventually going to grow into mature blood cells. And so if we kind of link up why that's significant from radiation biology perspective, we can see this is an area of a lot of undifferentiated cells, right? They're sensitive to things like radiation. But for us in the world of X-ray technology, this is also helpful from a technical point of view, because that medullary canal, since it's filled with this cancellous bone, has a unique pattern that we refer to as trabeculae, or trabecular pattern, right? And it is that almost crystalline type pattern that's seen very faintly on long bones anytime we have a proper exposure of the bone. So it is a way that we measure, similar to looking for the psoas muscles on a KUB. If I want to look at a forearm image or a knee image and say, yes, we use sufficient technique for this picture, I can look for that trabecular pattern. If I can see that cancellous bone pattern inside of the bone, in the inner portion, not in the areas where I'd expect to see compact bone, then I know that I have an appropriately exposed radiograph of that bone. Other things that are going to be helpful for us to understand is when we look for the diploe, right? This is specific to the skull, right? And it's an area that separates the inner and outer portions of the compact bone. So it is not responsible for bone marrow growth. It is unique to the bones of the skull. And it's similar in some ways to that cancellous bone, but it's different enough in its structure for us to give it a separate term. So don't get thrown off by that funny E with an umlaut or whatever over it. It's just talking about the cancellous portion of skull bones. The skull had to be unique in that regard. Oftentimes it's easy to think about the skull as a singular object, and so we'll be talking about that in just a minute when we talk about joints. Finally, it is important to recognize that this red bone marrow, which is inside that medullary canal, is responsible for all sorts of erythrocytes and leukocytes. So red blood cells, white blood cells, being familiar with those terms. Yeah, I think that's all I'll say about that. When we talk about cells in the bones, right, there's two big types that we need to be familiar with, and these are mature bone cells. The first are the osteoblasts, and they're responsible for bone formation. So they will line the medullary canal. They'll also be throughout the periosteum, which we'll talk about in just a moment. And they're responsible for reinforcing the structure of the bone and providing it strength. So they do that by thickening and ossification. So if you think about those are two separate things. Thickening means it actually appears thicker. You would see it on a radiograph, it would be thicker. Ossification has to do with this mineralization of the bone. So it's a formation of mineral deposits that contributes to its material density. Conversely, osteoclasts are responsible for breaking down bone. And you might be wondering, well, why would we ever want to break down bone? Well, within the medullary canal, we can harvest bone if we need calcium, right? So if the body is depleted of calcium, osteoclasts will be activated in order to break down bone inside the cancellous material there. And this allows for changes in serum calcium or serum phosphorus. So they are going to regulate part of how the body's metabolism is working. If we have a disease that's affecting either the osteoblasts or the osteoclasts, we would expect them to start to affect the bones in the way unique to what they typically do. So diseases of the osteoblasts will cause the bones to become too hard and brittle. Diseases of the osteoclasts will cause the bones to basically be eaten away from the inside. When we talk about different types of bones, it's helpful to think about whether it's a long bone, whether it's a short bone, small bones, things like the the sesamoid bones and stuff like that, which this chapter doesn't necessarily get into a lot of, but I would refer back to Merrill's or something like that to be familiar with that. What is going to be helpful for us is thinking about these different ossification centers, because this is a big part of how the bone growth works itself. And also, they're oftentimes apparent on radiographic imaging, particularly if we're doing a study of a child or something like that. So the diaphysis is this area of a long bone that's basically the shaft of the bone, right? So we'll refer to that as the diaphysis. The epiphysis is the area, generally an expanded end portion, and it's the secondary site of ossification. So we have a really good illustration of this here, where we have the diaphysis. Within that diaphysis is the medullary cavity, where that cancellous bone is found. But then towards the ends, we have these diaphysis, which are secondary sites of ossification. Not on this illustration, but still important to this, is between the diaphysis and the epiphysis, we have the metaphysis, right? And this is an area that's sometimes referred to as the growth plate or the growth zone. And it's between the epiphysis and the diaphysis, and it's allowing for bone to be added into that area. So it's allowing for the lengthening of the bone, for the growth of the bone over the course of the person's development. So they're particularly apparent on radiographs of young children. And as we age, generally these, as children, they will appear radiolucent. We'll be able to see through them. There's a small cartilage plate there that's fastening them together. But then as a person reaches adulthood, it will seal off, and growth of the bone will end at that point. All right. Last thing we'll talk about in terms of the bones and the A&P of the bones is, let's see, I've lost my slides. Just a sec. Is the three types of joints on the bones. So bear with me here for just a moment. This slideshow's acting funny. And this is found on the bottom of page 19, I believe. There we go. So there's fibrous, sometimes called synarthroidal. Syn means without, so that means without articulation. And these would be things like the sutures of the skull. They remain more or less cartilaginous up until the point of birth, and so this allows for passage of the skull through the birth canal, but then after that they begin to ossify. This is particularly important for modalities like ultrasound. One of the most interesting ultrasound images I think that's out there is ultrasound of the brain through the bregma. So we're able to get ultrasound images of the brain through these areas where the skull has not yet ossified, that are of equal quality to CT or MRI for brain tissue. They're beautiful images. But once these areas of the sutures of the skull begin to calcify and harden, we can no longer get those brain images. So it's really, ultrasound of the brain is only for that period shortly after birth, where we haven't yet seen this fibrous development of the skull sutures. And I think that was one of the Knowledge Bowl questions that we got right. I think it was someone answered correctly what the ossification center, the bregma or something like that. All right. Cartilaginous joints, or amphiarthroidal. If you're wondering like how to imagine these, I think about things like amphibians. They're not quite land animals. They're not quite water animals. So amphiarthroidal means that it doesn't quite move, but it does move a little bit. So these are things like the intervertebral joints, right? So we can call those amphiarthroidal. They kind of move, right? Another example of an amphiarthroidal joint is things like the joints of the clavicle. Those are amphiarthroidal. They kind of move a little bit. Then there's synovial or diarthroidal. Diarthroidal just means it moves in at least two ways. And so things like the knee. The knee is capable of movement both as a hinge joint and then also it's capable of doing some side-to-side movement as well. So it moves in all directions. So I guarantee you, at least something that we just talked about will be on your registry. I would guess at least 5 things that we just discussed will be on the registry. These 2 pages here at the beginning of chapter 2, really, really important terminology. We should just kind of have them on flashcards and just kind of be able to spout this stuff off all day long. Be familiar with what trabecular patterns look like on x-ray. Understand the significance of x-ray imaging of young children and how we see those metaphyses real clearly as radiolucent, all of those types of things. Also being able to label different joint types, being able to identify, okay, the elbow is diarthroidal, those types of things. Really, really high yield things to study. But let's talk a little bit about disease, because chances are some of these things you will see in the course of your work. I don't know, have I showed the kid president video yet in this class? Okay, we'll watch that here in just a minute. I'm a big fan of him. I think he's pretty great. He has, I believe, osteogenesis imperfecta. So I want to kind of put a little bit of a human face on some of these disorders and talk a little bit about them, because it's easy, I think, for us just to kind of adopt a scientific mindset and to only look at how these x-rays appear and to not really think about the human impact of some of these diseases. But this is sometimes called brittle bone disease. And so we don't necessarily need to know where the mutations are or what they are, but just know that there's 2 different forms of this. Osteogenesis imperfecta congenita, which this is present at birth, and this is very likely going to lead to death. So it means that the bones simply cannot support any weight at all from birth on. Right? Then there's osteogenesis imperfecta tarda, which means it's slightly slowed. And so this is something that will be seen some years after birth. And it can sometimes be led to stop sometime in adulthood. But these kids will experience frequent amounts of fractures and imperfect bone growth that cannot support weight. So here's an example of what we're talking about here. So this is a tib-fib radiograph showing bowed lower extremities. And this was recognized shortly after the child began to walk. Okay. Let's watch a little bit of this video. Okay, we'll do the same with achondroplasia. So I wasn't able to do that with all these disorders, but achondroplasia is also a very, very common bone abnormality. So this is the most common inherited disorder affecting the skeletal system. It occurs in 1 in 15,000 newborns. That's on the higher end, and that can range up to 1 in 40,000. The treatments for it sometimes can involve, for us as x-ray techs, a bone age image of the left hand. And we'll look at what we're looking at on that image so you're familiar with the image and you know what you're looking for. It's a very simple study to do, just a PA left hand. But the treatments may be using things like growth hormones, although the data is not really back on that. We don't yet have, since we started administering growth hormones, we do not yet know once the person reaches adulthood whether that has impacted things like their heart or something like that. That's one of the questions with the growth hormone study. Things that we often see associated with achondroplasia, again, I mentioned with the left hand. One of the things that we're looking for is whether there's a flute-like appearance at the area of the epiphysis. And so if you look in particular at the patient's left radius, towards the distal end of the radius, it's kind of flute-shaped like this. right? So the radius appears flute-shaped. It has a high angle in those epiphysis areas. Also, we're looking at the digits themselves. So in the area of the phalanges, they appear very wide, but kind of short, right? So those two signs are correlated with achondroplasia. I've also included a CT image, a 3D reconstruction. This is in the textbook. And then what we're seeing is what we're calling mid-face hypoplasia, right? So the cranial vault appears almost typical in its size, but the facial bones seem to be smaller in size. So that's what we're calling mid-face hypoplasia, a lack of development in the mid-face.
How is that skull?
It doesn't say. It does not say. I'm guessing that they're teenage, or at least teenage, maybe adult.
So the babies that have to wear the helmet, is that kind of the same thing, or?
Maybe it may not be. I'm not familiar with that.
I just know, like, when the baby's head, they'll put a helmet on to, like, form it better.
Yeah, I'm not familiar with that. I don't know. But probably one of my favorite kind of human examples of someone who struggles with this disorder is Peter Dinklage. He's an amazing actor. I mean, he was amazing long before Game of Thrones. But he's also been a good advocate for people with achondroplasia. And so let me just play just a little bit of this clip from him on one of the late night shows. Of him talking with the host there, because I think one of the things he asked early on, are you nervous, right? And I think that, I mean, he's both in character and out of character when he asks that. It's an interesting kind of question to ask a host. I think he's quite used to making people nervous, right? And it's something that he's got spider senses through the roof for, does this person accept me as I am, or is there something else going on here? And so there's an interesting back and forth there if you listen to it through his filter of, making people nervous, right? So I would encourage you, whenever you are working with patients with any one of these hereditary disorders, or working with their parents, caregivers, to meet them where they're at, to ask them appropriate history questions, and to not draw out or ostracize or criticize any part of how they do things, because they may require totally different they may require different accommodations for working through the exam, things like that. So for example, having step stools ready and available for them is important. Having ramps and things available communicates that you're there to accommodate them. Like, I think in particular about a birthday party that we had at our house for one of our kids, and I hadn't thought about it, but I knew that a family member was going to be there who would require a ramp to enter the house, right? So I built the ramp ahead of time. We had it there at the back door. We could accommodate this family member. But then one of my kids' friends showed up who has a disorder, and he requires an electric wheelchair to get around. And so he was able to use the ramp as well, right? And that kid's mom came up to me during the party and just said, I just want to tell you, thank you so much. Like, one of the things we dread coming to a birthday party is, are we going to be able to get our son inside, right? So we're thinking about that every time we go to a birthday party, and we didn't have to ask. Like, there was already just a ramp there. And of course, I said, yeah, I'm that kind. That's how cool I am. I hadn't done that for her son, right? But he wound up being useful, and it really made me think, okay, what are ways that without even having to say anything, I can express that I'm here to accommodate? I think that's very valuable to people. Okay, we'll look at a couple other congenital hereditary diseases. I don't necessarily have examples from these, but one of them I do want to mention. I've had permission to talk about it. So osteopetrosis, this literally means rocky bones, right? One of the ways that I remember this, if you look at that osteopetrosis, if you're familiar with the Bible, Jesus renames one of the disciples Peter. His name was originally Simon. He says, I will call you Peter, which means Petra, rock, and on this rock I will build my church, right? So that's the same word. It's the same Latin word, petrosis, meaning rock-like. So sometimes this is called marble bone or stone bone. The irony is that the bone density is increased, but the bones become more brittle, right? So we will see these intense radiographs where there's no trabecular pattern on this image because there is so much compact bone, right? This would require an increased radiographic technique for imaging. Okay, some things that affect the hand and foot. Syndactyly. We have an image of this in the textbook on page 25. It means failure of the fingers and toes to separate. And I remember in particular when I was very young, the Mid-South Fair, when it was over at the Liberty Bowl or whatever, would still have a freak show, right? And there was a group that would come through town regularly called the Lobster Boy and the Lobster Family, right? And you could pay money to go into this tent and to see this family play cards, basically sit around, smoke cigarettes, and play cards. They all had syndactyly, right? So it was a father, a son, and I can't remember who all else would be there playing cards. And I remember that at an early age, 11 or so, these people being exploited in this way. And they were known around this area. They were kind of frequent flyers at the freak show, as it were. So some of these things, that term is a really loaded term, and I'm not using it benignly. I know that it's a significant term, and it's part of our history here in the Mid-South to label people as other or whatever. So I would challenge that, now that I've learned a little bit more and understand a little bit more. And I'm a little bit ashamed of the fact that as a young kid, I felt it was okay to go and pay that money, right? Another example is polydactyly. This means extra digits. This is found frequently in a gene set that's associated with certain ethnicities in Russia. So we don't see it quite as much in this country, but in other parts of the world, it is more common. And then finally, clubfoot or talus. This is a disorder that actually Tom Wolfe has, and he's given me permission to talk to y'all about that. So just in continuing to kind of put a human face on some of these things and to meet people where they're at. This is something that's going to be more common in males than in females, and it causes the bones to, or the joints of the foot to kind of extend out, hyperextend out, typically on just one side. And so we may have to do a radiographic series similar to this, where we basically are trying to press the bones of the foot down onto the image receptor in order to image the degree of that hyperextension and flexion to the side. Okay, vertebral anomalies. So these are things like transitional vertebra and scoliosis, right? So scoliosis is an abnormal lateral curvature of the spine. It's generally not apparent until adolescence, and oftentimes it's corrected with a brace or possibly with surgery if the degree of curvature increases, I think, past 40 degrees or something like that. Then we may require some kind of actual surgery. So it's important to recognize that this affects females more often than males, and so as we're doing these series, we may have to do images down the length of the entire spine, and to shield our patients and to use appropriate techniques in order to make sure that we're keeping their radiographic exposure pretty low. Transitional vertebra, these are vertebrae that have characteristics of vertebra on either side of the thoracic spine. So what do I mean? I'll show you in the text on this image in the next slide. But for example, a lumbar vertebra that has ribs, right? Or a cervical vertebra that has ribs. So typically this will happen at the LS junction or C7, something like that. Finally, spina bifida is a congenital anomaly in which we have a failure to close the vertebral canal. And this often, again, happens at the area of the lumbar sacral spine. So here's images demonstrating each one of these. So we have transitional vertebra is the first, working from the left. And then also a transitional vertebra of the cervical spine at C7. We have a C7 rib. This can lead to some complications, so a lot of times that's treated surgically. The transitional vertebra in the lumbar spine, oftentimes no one even notices it until they're getting a radiograph and, oh, look at that, incidental finding. So it's not as significant, or it doesn't normally require surgical intervention like the C7 might. And then spina bifida, we can see that inability of closure of the posterior portion of, looks like the lumbar spine or maybe the sacral spine. And then the final image on the right is a scoliosis. Cranial anomalies can include things like early closure of the cranial sutures. So this can cause damage to the brain and alter brain growth. So we have a lateral skull series demonstrating just that. And then the final thing is ancephaly. This means that the brain and cranial vault do not develop at all. And so we have this image of, it looks like a KUB style image of a woman with a child that does not have basically a head. Okay, so I mentioned that the other area that we need to kind of dig a little bit deeper into is going to be in this area of inflammatory diseases of the bone, particularly the arthritis. But we'll begin by talking about osteomyelitis. This is anytime an infection enters the bone or the bone marrow. So with a trauma or with any kind of breakage, we've got an image on page 29. If some kind of infectious agent is introduced into the area of the bone, that can cause some serious problems, right? So sometimes we call it hematogenesis. This is going to be at the ends of the bones. So staph can cause an infection. If you can imagine, this is why we're so morbidly obsessed with MRSA and with staph infection around the operating room, is because of this. It's not so much if the staph stays on a person's skin, no sweat. But if it gets inside the bone, that's a big train wreck of problems that are following, right? So it is because of this osteomyelitis that can result from staph spreading inside the bone. This can happen also as a result of contiguous infections, so things like burns, sinus diseases that cause an abscess in the tooth or something like that. Periodontal infections can get really out of hand. We see this particularly among impoverished populations where people do not have regular dental care. They have what starts out as just an infection in their gums or an infection in the tooth, and it winds up spreading to the jaw, spreading to the ear. They lose hearing in the ear, and things like that. So kind of ongoing infection starting in the mouth that spreads to other bones. So when we are looking at this radiographically, let me see if there's images here in the textbook. Yeah, there are some. Image on page 30. We might see an area of what we call a sequestrum, and that's going to be dead, devascularized bone. So the bone itself has just died due to the infectious process. Sometimes around that, we may see what's called an involucrum, and this is an area where the bone has started to heal around that dead center. And so there's a new shell of supporting bone developing around it. So we have some images of that related to chronic osteomyelitis on page 30. Okay, just to make sure we're familiar with some of these terms, arthropes, I'm not saying that right. Arthropathies? I don't know what okay. Arthropathies, all right, is the big umbrella term, right? It's any kind of disorder of the joint. So things like arthritis, bursitis, tendonitis, I can't even say that one. I've totally like blundered my way through this. Just know that that's the umbrella term. The more common term, the term that I need you to know more about, is the arthritis. So that is inflammation within the joint, right? Joint inflammation. Sorry for that. So anytime we've got arthritis, if you look on page 31, I've underlined something here. Accurate clinical history is of extreme importance, right? because there's a bunch of different types of this arthritis, right? And they're characterized by specific features. So for example, it's important to identify the number of joints involved. How many areas of your body are hurting, right? It's important to know the location. What areas of your body are hurting? And then the presence of any other disease processes. Have you had a recent surgery? Is this actually an infectious process? Have you had tuberculosis, active TB? So there's other infections that can spread to the bone which could mimic arthritis. Yes?
So you're saying we need to ask all this before we...
Get this information, because if it just says joint pain or suspect arthritis, that is too broad. That is just too broad for us to guide a diagnosis. So ask your patients if they're there for joint pain, bone pain, rule out arthritis. That's too general. We need to know, where all are you hurting, right? Have you had other surgeries that may be contributing to this? And then what specific joints are hurting? Is it just your hands? Is it your hands and your wrists? Does it seem to be affecting your feet at all? Those types of questions are all important. So, an example of just how complex arthritis can become is rheumatoid arthritis. This is a chronic autoimmune disease. What does that mean? It means that the body itself is attacking the bones. That's what that means, chronic. Over a long period of time, the body is attacking the bones. And this can be triggered by exposure to certain agents. It can also just develop iatrogenically with an unknown source of causation. Oftentimes it's linked to a serological rheumatoid factor, so we can do a blood test and see that factor there. It does cause reduced life expectancy. So knowing that it's primarily affecting the patient's hands is significant. Making sure that the patient's age is recorded as well is also important. That's particularly true when we look at juvenile rheumatoid arthritis. So this has specific criterion developed by the American College of Radiology. They need to be younger than 16 at onset. So again, recording how many joints are being affected by this, how long this has been going on, and whether it's just in one area or throughout the body is going to be helpful in guiding this diagnosis. So I skipped over a number of the other types of arthritis. If we can focus on just rheumatoid arthritis and juvenile rheumatoid arthritis, I'm going to call that good. And just to know that that term relates to inflammation of the joints. Looking at other inflammatory diseases though, there's ankylosing spondylitis, sometimes called bamboo spine. And this is, again, these terms, the bamboo spine and things like that, you will not necessarily hear that being said in the clinic or anything like that. These are radiographic signs. So these go back some time, in the past when people would indicate, almost like saying that a cloud looks like something. So early on in radiographic history, you would have doctors who labeled certain diseases by their characteristics. And so this has the appearance of bamboo on an image. So this is going to mainly involve the vertebral column. And what we see is a fuzziness of the sacroiliac joints, and ossification of the spinal ligaments. And the bones start to fuse. Generally, this is treated with NSAIDs and exercise that's going to allow the bones of the spine to flex. But if you're wondering what you're looking at here, what you're seeing is a demineralization of the vertebral bodies and ossification of the joint. So it almost as though there's just this uniform bone now, right, forming the entire vertebral column. Even though we have ossification of the joints, the spine itself is going to become more brittle, right? Osteoarthritis, sometimes also called degenerative joint disease. This is the most common kind of arthritis. So again, knowing the areas that are being affected, what is happening allows us to differentiate this from rheumatoid arthritis. So in this case, what we have is degeneration of the joint cartilage and sometimes the formation of osteophytes or bone spurs. So this is really common in the lower extremity, particularly in the feet. Gouty arthritis. This is an inherited metabolic disorder in which amounts of uric acid are deposited in the joint space and the bone. So this is, again, typically going to impact the lower extremity. What we get are what we call tophi, which are crystalline deposits around the area of the ankle joint. And sometimes you see some swelling in that area as well. Serum blood analysis can guide this. And then another way that we can guide this is increased use of dual energy x-ray. So I'll show you what I'm talking about here. If I was looking at a general x-ray image of the hand, right, I would not necessarily be able to determine which of these bones in the wrist or in the fingers are being impacted by gouty arthritis, because the uric acid deposits look very similar to calcium deposits. So in terms of attenuation value, they're about the same in terms of x-ray. CT does not necessarily allow me to see very much either, right? So CT didn't help either, because again, the Hounsfield units is about the same for the uric acid and the calcium. But if I use dual energy x-ray, look, it lights up really clearly on this. It shows up as these green and purple spots on the image. So this is a dual energy CT image or dual energy x-ray image that's allowing us to see a difference in attenuation value for those uric acid deposits. So this is actually one of the best cases that's being made right now for dual energy x-ray imaging, is the detection of gouty arthritis. Some other terms that we need to be familiar with is tendonitis, just inflammation of a tendon. So differentiating, is this tendonitis versus arthritis, is going to be important. Tenosynovitis, inflammation of the tendon and the sheath around the tendon. Bursitis, inflammation of the bursa or the sacs around the joint. We frequently see that in the elbow or in the shoulder. And then a ganglion might be a cystic swelling in the tendon sheath. So we got examples of those on page 37. These are frequently going to be cause for MRI imaging, right? That's going to be the best way that we're going to detect these things. Looking within the vertebral column, we can start to talk a little bit about traumatic effects on the skeletal system. So whiplash, like soft tissue injuries caused by the vertebral column itself. And so we have an example of that here on page 38. Spondylolisthesis, so slipping of the vertebra itself. This is common at the base of the lumbar spine. So L5-S1 may require surgical correction. And then a oh my goodness. How do you say it? Spondylitis.
I like that.
Okay, all right, we're going to call it that. This is an erosion of the vertebral body itself, and we will see it on these oblique views if there's a collar around the Scotty dog's neck. So that's one of the reasons why we do these obliques. Cool. Finally, thinking about neoplastic diseases of the skeleton, we have benign things like osteomas, which are dense bones in the skull, osteochondromas, and giant cell tumor. These giant cell tumors can wind up becoming malignant. The main malignancies that we're concerned with are osteosarcomas. These are going to arise from osteoblasts. And so what again do the osteoblasts do? They form bone. And so we would expect these tumors to cause an overproduction of bone. Ewing tumor, and this is going to be common in children. And this is going to happen in the medullary canal with lesions spreading throughout the body. So anytime we have metastases of bony tumors, these can wind up in distant parts of the skeleton. And frequently it's going to be bones that contain red marrow that are going to be most commonly affected. And that's really it for the lecture today. You'll see we have kind of a hodgepodge of whether it's subtractive or additive here. Most of what we talked about today is subtractive in terms of technique, and there's a few additive things. I have seen quite a few registry questions that focus on the arthritises and determining whether the particular arthritis is additive or subtractive. So that's an additional area of kind of digging in that we need to do, is in thinking about the patient's arthritis. You'll notice I skipped over quite a bit in terms of cancer to arrive at this. So the final kind of piece of depth that I would say that we need to understand this stuff is, in addition to getting a good history from the patient in regards to what arthritis we may be looking at, it's being able to differentiate, is this going to be an additive technique or a subtractive technique? Because you can look, for example, at infectious arthritis, subtractive, psoriatic arthritis is going to be subtractive. So being able to parse that out with some of these is going to be really important.